Thank you so much for the opportunity. Opportunities like this, I tend to take the opportunity to present at least some new thinking. I was talking to Andrea McNeil recently about, who many of you will know, quite a dynamo surgeon, directs the Planetary Healthcare Lab at UBC, sort of has a planetary healthcare lead with Vancouver Coastal, planetary health lead, medical lead position with Vancouver Coastal Health Authority. And she was talking about giving presentations and feeling like she needed to come up with a new album. Because one of the sort of the way she was, the story she was telling, but I find myself constantly trying to modify because I learned through the process of thinking through different ways of engaging this topic. So there's sort of two parts to what I want to talk with you about today that I hope reflect the interest. One is to scope out the problem. And as I am a policy person at heart, I'm going to do this a little bit more from a sort of a think forward to 2100 perspective. What kind of health systems do we want to build? And then the second part of my talk will be, well, what's happening globally, nationally, locally, provincially. Certainly, I have a particular perspective. I don't claim to know everything, but I can give you, my own perspective on what's happening. And I hope to connect the two by reflecting a little bit, and then I suppose asking folks here the extent to which the nature of the challenge before us is adequately being addressed given the nature of the mobilizing that's happening. And I suppose that's my question. So as I say, I want to start by asking what do we really mean by that? I'm going to start with an image, not because you folks need the IPCC material recited to you. Everybody's quite familiar with the sixth assessment process. I show this to point to the diversity of pathways. So this is the first working group report of the sixth assessment process from the IPCC. And so this is one of many of the images, and they're showing us a possible set of futures in terms of global surface temperature change relative to sort of the intensification of the Industrial Revolution by 2100. Bunch of numbers there, what's going on. Here's another similar image going in the opposite direction in some ways, frankly, more worrying, ocean acidification. But again, I show it here not so much to talk about the nature of those futures, but to pose the question, what defines and what drives, these different futures? What's going on here? And so I think our usual answer to this question is to say that what drives these different futures is, in a sense, our climate policy, how we act on climate policy. And of the numbers over there on the right-hand side, the 1.9, 2.6, 4.5, 7.0, 8.5 are sort of gesturing in that direction. Those are the representative concentration pathways. That's the sort of climate science taking into account different kind of emissions scenarios, land use scenarios, and mapping out the range of sort of credible extremes. And this was all sort of done somewhat recently, the last 10 years or so, that are in a way, could characterize the possibilities that climate policy would drive. Let's go with that. But that's not all that these images are pointing to. There's something else going on, and that's those SSP letters, SSP 1, 2, 3, skip 4, and 5. So what those are about, those are called shared socioeconomic pathways. And those are pointing to a analytically distinct question than our climate policy, which is how we organize our world anyway. And the question is, the climate future, the ecological future that we will realize is a function of both of those things. Another way of thinking about this is that all policy is climate policy in a climate constrained world, but I think it's more sophisticated than that. So digging into that a little bit. So this is one of the key papers that shows us these shared socioeconomic pathways, these scenarios, and I'll explain them. What I want you to see here is, again, how they independently, in a sense, because that's the intent in constructing them, independently, they are giving us quite different climate futures in 2100, as you can see, from SSP 5, the worst case scenario, SSP 1, best case scenario, relative to those representative concentration pathways. So those are estimates of basically sort of climate forcing and the difference between energy out, energy in. We're in a very unstable time right? In terms of our climate system, when energy out is not balancing, so we're increasing our heat. So that's what those are estimates are. So you can see that those shared socioeconomic pathways don't get us to where we want to be, which would be the lowest sort of RCP that's not even here, wasn't particularly on the in the space when this publication was put out there. So what are they? So here's what the shared socioeconomic pathways are. They were devised, as I say, to try and define a challenge space for the future, for 2100, to say, where might we be in terms of the way in which we organize our world? And what are the they created 5 different scenarios that created different types of challenges. And as you can see, on the x-axis, these are challenges for adaptation. On the y-axis, these are challenges for mitigation. So our best case shared socioeconomic pathway, the way in which we live in this world, sustainability, and the attempt is to be independent of climate policy, right? But in that vision of the world, folks are pursuing not just GDP growth, but a well-being economy, a sharing of the fruits of our collective labors and of the richness of the planet we inhabit in a much more equitable way, in a much more sustainable manner with respect to the natural world around us. And so independently of trying to tax carbon, or trying to transition to green vehicles or related acts, that is a world that a priori is easier to achieve climate mitigation and easier to adapt to the existing climate shocks and stresses. And so we can go to the worst case scenario, what according to the sort of folks who put this together, they characterized as regional rivalry. And I could quibble, but I think it actually does in many ways characterize the world we're increasingly inhabiting, which is growing tensions between the US-centered empire, Russia, China, and growing militarization, growing investments in military equipment, declining global cooperation, intensification of coal burning in Europe, challenges with access to resources. So this is a very, very rocky road. And so this is a scenario where you would see growing inequality in terms of the distribution of access to power and access to resources and the benefits of opportunity, as well as extremely intensive use of our resources and exploitation of our energy systems. And then we can have different scenarios like fossil fuel development, where everybody gets everything. Everybody's got a jet, it's equal, but it's incredibly intensive. Or a road divided, SSP4, which is really a sort of a scenario of a global elite, Davos times, where there's a small global elite that has a ton of things and most of the rest of the folks who have nothing. So a relatively limited challenge for mitigation, because that global elite can, use biojet fuel and run their castles on renewable energy. But the rest of the folks are not able to adapt to shocks and stresses. So that's the picture that the shared socioeconomic pathways is telling us. So now, just to translate that, what I want to do, where I'm going from this, is to health systems. And just to iterate what that when we think about climate and environmental impacts for health systems, we're thinking about greenhouse gas emissions. We're thinking about a broader set of environmental harms, some of which, like pharmaceuticals, are really quite specific to our sector and are oftentimes really quite toxic. They're designed to be so, right? Bioavailable, to not degrade, things like that. And then adaptation, the risks to health and the risks to our capacity to provide services and systems. So my question, and what I'm working with, what I'm imagining, what I wanted to share with you is, if we tried to create a similar challenge space for 2100, to define health systems, shared health system pathways, what kind of health system, independently of our efforts to green the operating room, to reduce the use of high carbon inhalers, to bring renewable energy into our hospital systems, or shift to green ambulances, what else is going on? What other aspects of our health system would we imagine would set us up to either have high or low challenges for mitigation, y-axis, high or low challenges for adaptation. And so I have my own kind of story here, which I'll briefly share, but you folks may have reflections or criticisms of my scenario. But I would suggest that SHP1, the vision of the health system of 2100, which sets us up independently of climate policy to manage much, much better in a climate challenged world, is a world of high touch and lower tech healthcare, highly appropriate, built into a sort of a caring economy, lots of labor. The whole vision for the sort of eco-social contract that many folks are thinking about, that is obvious, that is about access to high quality healthcare, but also social care, housing, transportation, education, a sort of a system of universal access to basic goods and services. So health and social care being very much part of that. And so I would stress the high touch aspects of this and the caring aspects of this and the rebalancing towards primary and community-based care. Yes, there will be high tech aspects. I'm not trying to get rid of that entirely, but just less unnecessary testing, screening, interventions, better conversations with patients about their needs, better supports and strength-based approaches to linking folks to what they need to stay healthy and well. So that's one vision, which I would suggest sets us up well vis-a-vis environmental harms anyways, or risks and adaptation threats. And then we could imagine, my scenario for the high challenge space, I kind of imagine Health Inc., a sort of a growing constellation of competing private equity owned care enterprises that are trying to feed us all sorts of, or some of us that can afford it, all sorts of high-tech, unnecessary full body screening and major data, AI investigations of every Sunday, whatever, but it's inequitable. So it's really, really energy intensive and resource intensive, which is a problem for mitigation. And it's, on the other hand, it's not providing any kind of system of care or support that would give us a leg up on adaptation. And you can imagine the different scenarios, the inequality, SHP4, with the global elite, with their access to everything that they want, that they can green, and nobody else has anything. And then the other, everybody gets everything. Everybody's got the highest tech healthcare. It's equitable. It's equally distributed. It's fair in that sense. But it's a disaster with respect to the mitigation issue. So that's the storyline from, I think, a system perspective. And I think it's very helpful to think about that and to really frame this around the health system we want, not just the particular adaptations that we need to make that are environmentally oriented. Because a big chunk of what we're trying to do has got to be about the health system itself. And this lines up with existing frameworks for sustainable health systems or sustainable health care that many of you will be familiar with. So some of you may be familiar with the work of our colleagues from England. So the Centre for Sustainable Health Care, which is based in Oxford in England and has been around since 2008, has, I think, really pioneered the work to link sustainable health care to quality improvement. And we're a central part of having that sort of modification of the understanding of quality improvement in the UK to create a seventh dimension. So typically there's 6 dimensions under the Institute of Medicine model from the US. So a 7th dimension being sustainability. And so that's hence the driver diagram, a classic sort of QI approach to thinking. But what you see then in the application of this kind of quality improvement thinking to sustainable healthcare is the way in which we are conceptualizing the problem very, very clearly around first reducing activity and secondarily reducing carbon intensity. So this kind of framing of it, I've put in light green the more facility-oriented aspects, but so much of this is clinical. And so much of this is in service delivery and system design. And obviously, the ways in which healthcare is coordinated with other aspects of our social care system or social supports. So that's one. Another that you might be more familiar with is this beautiful framework from Andrea McNeil, Forbes McGay, and Jody Sherman, that they call planetary healthcare, which is very similar, slightly differently conceptualized, but fundamentally helping us to see the challenge in the same way, to start right at the top with reducing demand. Not easy to do. Much of this can't be done from within healthcare, but some of it can. And then we get into matching supply to demand, and appropriateness plays a critical role there, other forms of stewardship, but also that gesture towards the rebalancing, trying to big up those aspects of our system that that really need to provide that, continuous first contact, comprehensive care, link folks in strength-based ways to their community, to the services that sustain their well-being. And then we get into all the things that, yes, are important, but are, in a sense, must be the sort of final, in a way, change that we make, even though many of us, myself included, who do work on sort of environmentally sustainable healthcare, kind of start at the bottom of the pyramid rather than the top. So here's my modification, if you will, of both of those frameworks, just because I think we need to have both mitigation and adaptation in view. And many of you will know that when it comes to climate and the threats that it poses to health or health services and systems, that there are very important things clinically for folks to be thinking about in terms of whether it's vector-borne diseases or it's heat and the greater risks that certain medications pose. Somebody told me recently that of the more than 600 folks who died in the heat dome in the summer of 2021 in the Lower Mainland, almost a half were schizophrenics. So not even just mental health, like just a huge, so this is, structural, it's behavioral, and it's possibly medical in terms of, those medications. And Jilly, you may well have greater insight into that. But there are clearly issues for service delivery, clinical practice, system design that bear on adaptation. So just to suggest that I think our framework needs to include both aspects of the equation. How am I doing for time? I have nattered at you already for quite a bit of time. Okay, so that completes the first part of my talk. What is the nature of the problem? And I hope what I've suggested is that it is not only as important as greening the operating rooms are, it is not only that. There is a whole infrastructure of service, of system design that we really do need to reform, and that we, in many, many ways, have been for decades talking about, but actually need to get on with. So then where are we at? So many of these things, again, you will know. I will start with NHS England. We're often looking across the pond. I start there simply because they've been at this for a long time. The Center for Sustainable Healthcare started in 2008 as a sort of an independent NGO. The SDU started in 2008 because somebody had the brilliant idea to sort of embed a unit within the NHS. And I think they built beautifully. They really built capacity and knowledge. And then Nick Watts put it into overdrive when it was transformed into the greener NHS service. However, I would also say by a narrowing of its ambition from sustainable development to carbon almost exclusively and climate change. And it may be worth talking about the concept of carbon tunnel vision. But in any event, a very impressive and world first commitment to be net zero that you're well aware of, and a net zero commitment that has encompassed this expansive territory of those things we buy. As you're probably aware, the commitments that countries make, the nationally determined contributions under the UN Climate Change Protocol, are for production emissions, the emissions that are produced within your territory. Healthcare is appropriately taking responsibility not only for the emissions that it produces within its walls, but for all of the emissions that it creates, that it invokes, that it makes happen, whether they're in Bangladesh, whether they're in London, Ontario, or Mexico. They are actually still the responsibility of the service provider. And that vision and that commitment and accountability is I think incredibly important, and has carried and has continued. So and I would credit the SDU with moving us off in that direction, in that very important direction. I name the US as an actor in the space because for us in Canada politically is very important. I'm not sure, I mean, if Jody Sherman was here, she'd probably have things to say about the National Academy of Medicine Action Collaborative, the Office of Climate Change and Health Equity that is embedded within the Department of Health and Human Services is on the one hand incredibly powerful because it's within this massive department, Federal Department of Health and Human Services, and able therefore to reach across the very large range of portfolios that exists there and get conversations going. It's also powerful in its ability to direct the federal health services, the Indian Health Service, the Veterans Affairs, but beyond that, it is relatively powerless. Although there are instruments it can use, but I sincerely doubt it's going to use payment mechanisms or requirements. So it's really moving down the voluntary pledge role, but very important for us because, you know, it shamed us, it shamed Canada into signing on to this very important UN Climate Change Conference. Again, many of you will know this story. In fall 2021, the first formal health program at one of these United Nations climate change conferences, very much again because of the UK. The UK was the primary host of this. The NHS in England did a lot of work. There was quite a lot of work done behind the scenes, or at least a year before, to get this commitment forward. A call for national commitments in Canada in the person of Stephen Guilbeault signed on. And I would credit Courtney Howard, who was there among others in really driving that to a very successful conclusion. And I understand from Courtney that the US signed on before Canada. That was probably one of the reasons why I put them in this narrative, is because that was important for us. Canada is unfortunately not being a leading figure on many issues. We're quite a follower. But good work has come out of that. So globally, one of the key things that's come out of the COP26, and then not a lot happened to reinforce that at COP27 last year, or who knows, this fall, as I like to say, beyond my pay grade. But the Alliance for Transformative Action on Climate and Health was sort of launched out of the COP26. It's coordinated by the World Health Organization, and I think it's something like 65 countries that have signed on to one or both of the commitments: climate resilient health system, low carbon sustainable health system. So there are 4 working groups: low carbon sustainable, climate resilient, supply chains, and nutrition is the new one. I and several other folks from across the country are participate in some of these, and it's very interesting and important work in many ways. Many of the countries with very ambitious commitments are lower or middle income, even low income countries, and low sort of lower end of high income countries. And so ATTACH, as one would expect from WHO, is really trying to mobilize co-leadership between high income and low middle income, and the exchange of the knowledge and the expertise that must be exchanged in this context. I'm forgetting there's also a financing, vitally, there's a climate finance working group. So another more recent initiative you may have heard of on the global space is the Lancet Commission on Sustainable Healthcare. So this is my colleagues and incredibly impressive characters: Jody Sherman, Andrea McNeil, names that will come up often over and over again. Jody at Yale and Andrea at UBC are the co-chairs of the Lancet Commission. It started out as the Lancet Planetary Health Commission, has become a Lancet Commission adopted by the parent journal. There are, in fact, hundreds of these commissions, but it's still quite important. And they've done just a tremendous amount of work to really galvanize a global network of scholars and an executive committee for working groups, and also tremendous work to connect ATTACH, which is trying to do this on a really practice-based way, to the Lancet Commission, which is really trying to advance this with the benefits of research and scholarship and the rigor of bringing people, many of whom aren't embedded in the health sector. They're coming at this from other spaces of doing sustainability and resilience work, which really deepens our capacity to think deeply about the challenges. So that's very important. And I think, it's challenging, but lots of work to create synergies around the sort of evidence and research enterprise, particularly around some of the things that everybody wants, which is metrics. And that leads me to this third and still more recent initiative out of the OECD. I'm not quite sure when they got started on it, but the first working group meetings are next week. So this is Working Group on Health and Climate Change Indicators, quite important because, the OECD is the health data place. WHO data on health and health systems is not strong. OECD is very biased. It's the high income country club. But they definitely have some more data beyond the highest income countries, but they really are a repository of data. So if they need to get this right, because everybody will be looking at health systems and comparing health systems, or many folks will effectively be forced to use OECD data to do this, because there are simply no other databases that have the kind of quality, depth, and consistency in updating as the OECD. So that's a really, and again, Andrea and Jody have connected the dots between the Lancet Commission and the OECD Working Group and are part of that work. So we will see where that goes. Performance measures are both essential and deeply problematic. You can't manage what you don't measure, but if you measure it, you can barely manage it. I can't even remember what some of the phrases are, but it's not a simple art or science. So turning now to sort of the Canadian context. I mean, many of you will know that we have within Health Canada, so the federal government level, and have had for quite a long time, a climate change and innovation branch that has hosted and still does some leading scientists on the question of climate adaptation and health system resilience. And that orientation to the health system as an issue for adaptation is very present in the federal government's sort of policy space related to climate and health. It's very much about adaptation. It's very much about classic critical functions of public health in terms of alerts and reaction to extreme events and trying to mobilize communities, and somewhat weak links to care delivery systems, particularly in a place like Ontario, but even so in other parts of the country where technically the connections are stronger. But there is growing, with that COP26 commitment, there is growing engagement with the health system, the mitigation challenge for health systems. So it's embedded in some of this literature. The Government of Canada Adaptation Plan has a little bit of it. The Climate Science 2050 has a little bit of it. The Adaptation and Health System Resilience Chapter 10 has a little bit of it, and the Mobilizing the Chief Public Health Officer's report from late last year has a little bit of it. So I think my next line is always the federal government is a very, very long way away from healthcare delivery in the provinces and territories across the country. But nonetheless, it's an important supportive environment for the kind of pan-Canadian policy development that I think we need to do. And then the provinces vary enormously. I don't know that anybody would challenge me if I say BC is way ahead of the pack. So BC has, since 2008, had a sort of a climate change legislation that has driven the broader public sector to estimate its sort of direct emissions and manage and pay offsets for those costs. So health authorities have been paying bills for their directly controlled emissions since around 2008. That has really caught the attention of the health authorities slowly but surely. They've built, obviously, the leading expertise on our infrastructure, how it can reduce its climate harms and environmental harms, how it can be resilient in the context of stresses and shocks, and really set the stage for folks like Andrea and her colleagues to build, the deep connections that are needed between some of that traditional greening healthcare work that tends to be facility managers and energy stewards and waste management folks, to the clinical and the service kind of design folks over on the other side who are more connected to quality and also to public health. So BC's way ahead. And this fuzzy image that I'm showing you here is, I think, really important because it's Even though it's 2008 that the health authorities were starting to be driven to pay attention to climate change, they were being driven by, actually, I don't know what ministry it was, but it wasn't the health ministry. But around 2019, so that's still a while ago now, the Ministry of Health started to include climate in its mandate letters. So when the Ministry of Health sends a mandate letter to an executive authority, to the executive director of a health authority, the minister says, here are the priorities. And in 2019, it was all these priorities plus 2 things you must keep in mind: align your work with our climate ambitions and engage in Indigenous reconciliation. And so that and those kinds of high level, it has continued to be there. That's really important, because what we will find typically across the country is that guidance for the health sector to address climate is not coming from health ministries. It's not coming from the governors of the health sector. It's coming from environment or energy. And so that tends to be a different world in terms of who they're connected with. Alberta, I put Alberta up here because it's not a supportive environment in many ways for the health sector to move. But in the depths of the pandemic in August of 2020, the health service, so the governing agency for big chunks of the health sector in Alberta, created its own policy on environmental sustainability, challenging itself to measure and manage more of its emissions. And Quebec is interesting. The Ministry of Health is engaged, Health and Social Services is engaged in Quebec, and Quebec has always understood these things under the auspices of sustainable development. This is old. I know this is 2020. The new one is in the works. And so there is engagement. Lots of folks here may know better than I. I have some knowledge and connection of Quebec, but interestingly, different framing. And in the tradition of improvement in health policy in Canada, and I'm a health policy prof, I would say the opportunity before us is to leverage the excellence, those pockets of excellence that exist and these are only 3 provinces, but across the country, share, spread, and scale. So folks are very aware of the engagement of professional association, obviously the faculties of medicine with their pledge, the Royal College with, CanMeds, Hussein Malou and Samantha Green, who are co-chairing that, reform of the CanMeds competency. So there's lots happening in medicine. As you know, the CFNU, the Federation of Nurses Unions, has been the most active sort of association, nursing federation sort of nationally on this, and they're working with CANE, I understand, on a new toolkit on planetary health for nurses, which is brilliant. And I'm super excited to see the relatively recent, but quite frankly, explosion of interest within the pharmacy community, the recent launch of an association like CAPE. I mean, these are not all of the things, as you know. I don't have CAPE here. There's lots of, Samantha Green was saying CAPE has 17 staff now or something like that. It's just extraordinary. But CAPHE, the Canadian Association of Pharmacy for the Environment, was forged last year, and they, with the Canadian Society of Hospital Pharmacists, are co-chairing a new environmental sustainability task force. The Canadian Association of Pharmacy is getting engaged. So I think there is a mobilization of professional associations in ways that are obviously incredibly important. And then, I don't know if I'm talking for too long. This is usually where I end this part of a talk like this. When I talk about what's happening, I say global, I say national, I say provincial. I've thrown in professional associations, given audience. And then I say, but to make the change, we will need folks on the ground, and we will need folks in their settings, not just on a, Joe does his thing and Joanna does her thing, but within communities of practice that are coherently organized to sort of innovate, to figure out some of the work that has to be done. Even if it's been done in England somewhere, it still has to be figured out in Ontario or in Southern Ontario or Northern Ontario or Northern BC. And so this, I always say, because it is a very, very partial sort of scan of groups, because these are the ones that I work with most closely. If we have a few more minutes, should I'm happy to stop here, or I'll take you through my more sort of for what it's worth, the particular communities of practice in a bit more detail that I'm most closely engaged with, which includes, does to go forward or end? I'm looking at Jilly.
Yeah, I think that you should go, definitely.
Yes, continue. You're going to say stop.
No, no. It's very interesting. So many details that I didn't even know. So
Everybody says,
if I may.
yeah. All right, I'm going to start here. So in terms of work that I put a lot of time into, like a lot of time into. I have for almost, well, 3 years, put a lot of time into, I'll call it a community. We call it the Sustainable Health System Community of Practice. And I will acknowledge that that is aspirational, because a community of practice is a community. And I think we're not there yet. But I think we're growing. We started, and much of our success has been by getting to the CEOs, the CFOs, the VPs, the deans, and create sort of a beginning with a coalition of the willing. As many of you will know, the Toronto Academic Health Science Network is quite a large, quite a sophisticated academic health science network. Canada really is like the birthplace of the Academic Health Science Network. Many countries try to imitate what the ways in which these things work. And we have a quite effective one here in the Toronto area, because it's not just Toronto. TASN actually spans both the cities of Toronto and Mississauga, because Trillium is Mississauga's hospital system. And we had a first 2-year term, and we did work in these 5 areas that were really my team, my center supporting folks to really do terrific work. We've had a renewal and an expansion that that has been really exciting, if not exhausting, to work on, because we've got a leadership table with representatives from all TASN hospitals, regular representation at the CEO table, meeting with them again in a couple of weeks to give us our year 1 report. Tremendous engagement led by Anita Rao on our perioperative care scorecard. Tremendous work on sort of primary care, led by Samantha Green, Kimberly Wintemute, Karen Cameron. Karen's pharmacy, and Kimberly and Samantha, both primary care physicians. Tremendous work that is, I think, really, innovating, really trying to work together to figure out new ways of doing things. And for me, because I'm an academic and I spend my life in an office, this is my closest connection to sort of tangible practice change, to leaders, to service, to the work that goes into trying to think about how to change, not the clinical practice so much, but the service organization, the delivery, and the systems, and some of the work that we're doing in terms of like our balanced scorecard. So, corporate performance, how should these hospitals judge their performance in this space? And then I'm super excited that we have been embedded as TASN, as a collaborative, has actually strengthened a lot in recent years, in the COVID pandemic. Put that on steroids, really, because it required more collaboration. That its first strategy framework for TASN now has this 4th of 4 priorities, which is an equitable and sustainable future. And I think very appropriately connecting the dots, linking together the need to dismantle systems of racism, focus on anti-Black, anti-Indigenous racism, ensure a lens of equity, and reduce healthcare's contribution to climate change, and implement measures to mitigate problems. So that is the precursor to, for me, predates by a year, our great good fortune in getting funded to create what we call Cascades. So this is a project. It's funded by Environment and Climate Change Canada. We applied for the full amount miraculously, somehow. These things just happen sometimes. We got it. And it's a community engagement grant. And they said, what community needs engaged in climate action and awareness? And we said, healthcare. And the we is my team at the center, my colleagues at the Healthy Populations Institute at Dalhousie University, colleagues at the Planetary Healthcare Lab at UBC, and an NGO, the national NGO that's been in the space for a very long time, more than 20 years, the Canadian Coalition for Green Healthcare. So we try to work, our conception of what we are trying to do is to build capacity. Principally, I'll focus there on courses, innovation, support, principally by working with teams to help them, or to just translate the work that they do to make change, climate conscious inhalers in pharmacy, in primary care or in inpatient care. We had amazing work done that's going to be published soon from Island Health in British Columbia on inpatient management of inhalers, or perioperative care, working with the Ontario Surgical Quality Improvement Network and OMA, Environmental Sustainability Working Group, that section of the Ontario's anesthesiologists, to help to do that kind of work. So local prototypes and national spreads. And then increasingly, we try and do a certain amount of coordination. The Pan-Canadian Communities of Practice have done work on greenhouse gas emissions estimation. And then we're thinking of our work as falling into two pathways. One, very clinical, trying to think about as a pathway, because it should be a comprehensive way of thinking about the whole care, not just the greening the operating room, but the perioperative care. Hard to do in practice. What we've been able to do, I think, is effectively connect to Choosing Wisely Canada for our major initiatives to really connect the dots when it comes to either inhalers or perioperative care between the aspects that are rooted in appropriate care, start there, and then again get into some of the climate specific activities. And then really, I think we're doing quite a bit of work and need to do work around leadership and system change. So then the possibly more biographical than is, or autobiographical than is helpful. I feel like our theory of change, for good or ill, with the community, with Cascades, where it comes from is the work I've done here or tried to be part of supporting here in the Toronto area. Our colleagues in Dalhousie have a similar relationship with Nova Scotia Health. Andrea McNeil and her colleagues at UBC have an extraordinary link to Vancouver Coastal and BC Green Care, which is the Lower Mainland sort of greening health facilities expert team. And we have, so in terms of our boots on the ground as Cascades, I think we're really rooted in those three places. It would be lovely to have more of that in many places. We're connected to universities. That's sort of our core model. Whether that's the right model, I think, is an open question, but that's what we are. And then the coalition, where we've tried to recreate that to some extent in Quebec, working with Synergie Santé Environnement, which is a sort of it's a social enterprise that's been around for 15 years, working with the Réseau on various sustainable development initiatives. And then with them and others, oh my gosh, I'm going to remember her name, but it's not coming to me at the moment. That's terrible. Start helping to support the Réseau d'Action pour la Santé Durable du Québec. So that's our core partner in terms of the health network that we work with, that crosses professions and sectors across the Quebec Réseau. So it's quite different, but nonetheless, an attempt to, in each of the places where we're situated, have those meaningful sort of groundings with health sector partners. And then I think many of you know Miles Sargent and know Peach, which really got started when with no money, when Cascades got started and has taken off and done extraordinary work. And now with Miles as CEO of the Canadian Coalition, we work quite a lot with Miles, and obviously we work with the coalition to try and find points of synergy and collaboration. And then, so I'm coming to a close. I guess, you know, the obvious, we face a lot of challenges. We need to adapt, and we need to reduce the harms. I want to go back to my first point. As we do this, and I know that I know that I don't always do this, but I believe we should do this, that we need to build a future for health systems as we try and make them more sustainable, as we try and build the planetary healthcare system that folks want, that it isn't just how we act in healthcare in ways that are specific to climate and other global ecological challenges. It's how we organize healthcare at all within broader systems of care and support. And that we're seeing an enormous amount of engagement. It's just taken off like a rocket. And so the need for collaboration will just grow with that. It's going to be challenging, but we have to keep trying. And I think we have to keep asking ourselves the question that certainly I think I'm trying to ask myself this evening, about the extent to which the work we're doing is deep enough and transformative enough for the challenges that we actually face. So I'm going to stop there.